Hello, my name is Lexi Adkins. I work in the emergency department at UK. I'm going to be doing my case study on a patient, we'll call her Sarah, who came in and was diagnosed with IBS. So Sarah came in, she is a 22-year-old female. Her main complaint was diarrhea, and this was a chronic issue for Sarah. But she came in because it had gotten worse and she felt like she just couldn't go through her daily life, and felt like she needed to seek treatment just to get her symptoms under control. She never had any previous diagnosis that was had anything to do with her diarrhea, so she really had no answers of why she was having these spells. She also said that she had some abdominal bloating and that she was nauseous, intermittently nauseous. So a little bit of background on Sarah. She had a history of anxiety, which she was taking Xanax at home for. She had been through multiple anti-anxiety medications before, and she had just gotten switched over to the Xanax. She also had, of course, this chronic diarrhea problem with no prior diagnosis that was related to the diarrhea. She also says that she had been in a lot of stress. She was 22 years old, about to graduate college, and that she was applying to med school. So she was kind of going through a lot of stress, a lot of life changes. She said that she had increase in caffeine intake over the last several months, but that she had a caffeine problem for multiple years. It had just gotten worse over the last several months. Prior surgeries, the only thing she had ever had was an appendectomy when she was 12. No other surgeries. Family history of diabetes and hypertension on her maternal side. Nothing on the paternal side. So whenever she came in, we just did some labs on her. Everything pretty much came back normal. We did a beta HCG just to rule out a pregnancy, which of course came back negative. Her white count was 6,000 within normal limits. We ran an albumin, which came back 4. We ran a stool to check for occult blood, which also came back negative, and ran her urine, which came back for no bacterial growth or no UTI. Upon physical assessment of Sarah, she did have some hyperactive bowel sounds, and she complained of intermittent nausea. We gave her Zofran just to kind of keep that under control while she was inpatient. Upon palpating, she didn't have any abdominal pain, but she was pretty distended, and she said that she was having increased bowel movements and that they were all very loose diarrheal stools. And this had been going on for about 2 to 3 days, she said. She had no vomiting, no blood noted in urine, no vomiting blood, no blood in her stools. She seemed to be a healthy weight. She was about 5'5" and weighed 145 pounds. She said she hadn't noticed any weight loss or gain recently. No urinary problems. She didn't have no problems going to the restroom. Again, no blood noted. And her last menstrual period was last month, and she says it was normal for her. All other body systems were within normal limit. So really all we had to go off of with Sarah was really just her symptomology and her history. Because of her age and with her having no prior history of anything that has to do with the GI tract, it really was a rule out game. So we did abdominal CTs, and they also did an ultrasound. Both of those came back negative and did not show anything. And really we did those diagnostic testings just to rule out things like bowel obstructions. She had an appendectomy, so we didn't have to rule out appendicitis for her, gastric ulcers, anything else that could be causing her pain, and the diarrhea, increased diarrhea. Again, history is most important for Sarah, and just the symptomology. So the patho on IBS really is kind of unknown. The etiology is completely unclear. There is multiple risk factors that are known. Environmental is the number one risk factor, and this includes increased stress, changes in routine, increased caffeine intake, or that can also go along with dairy products, sodas, coffees, things like that. Sarah, of course, had both of these. She says that she was under a lot of stress lately, had a lot of changes coming up with her trying to get into med school. And then her increased caffeine intake over the last several months. She said she'd been drinking black coffee multiple times a day. Some other risk factors that go into this. Some people say that it can be hormonal, and there's really no case study that follows this. It's more of people noticing that it is more prominent in females versus males, and so they kind of justify this by hormonal status. And then stress is, of course, another risk factor. It's also been shown that people who have been diagnosed with IBS, they usually will have an increased intestinal bacterial growth. With IBS being such a chronic disease, and it's a very difficult one to kind of put your finger on a diagnose, especially in an acute emergency department setting, it's kind of hard to say that she had increased bacterial growth. But this is a risk factor, and it is found in most people with the definite diagnosis of IBS if they do have this bacterial growth. There's multiple types of IBS. The first one is IBS class D. This is the type that Sarah was diagnosed with. This is increased diarrhea over months and months, years even. It's a chronic disease. So you just have bouts of diarrhea that is not really respondent to the normal medication, over-the-counter medications. IBS-C is mainly constipation. That's what most people will complain of, just chronic constipation. Again, that does not react to the normal over-the-counter medications. IBS-A will alternate between the two, so they'll have bouts of constipation for days, weeks, sometimes months, and then they'll go over to diarrhea. They'll have these symptoms for a certain amount of time and kind of alternate between the constipation and diarrhea. IBS-M, this is a mix between the two. This is pretty common. People with IBS, and again, these are all just types of IBS. They kind of all fall under the same umbrella. These are all just based off symptomology of your patient. IBS-M is just a mix between diarrhea and constipation. You really don't stay in one state or the other for any amount of time. You kind of just alternate between the two. So treatment for Sarah, we gave her a lot of discharge teaching before we sent her home. The main thing was to increase dietary fiber. We wanted her to have 30 to 40 grams a day of fiber, and just teaching her how to get that in her diet in a healthy way, and just making sure we're trying to bulk up those stools and get rid of some of that diarrhea for her. Decrease stress. This was something that she was going to have to kind of do on her own. It's a lifestyle change. We went over with her before we discharged just some coping mechanisms, maybe picking up a hobby, running, exercise, some reading, something like that could kind of decrease her daily stress, and increase fluids. This is more to combat the dehydration that can come with diarrhea. So making sure she was drinking 8 to 10 cups of water daily. Medication she was discharged with, Imodium, and that is just an anti-diarrheal medication. Psyllium, this is a bulk forming medication to, again, try to bulk up those stools so they're not so loose. And then Elavil. The reason that this works is kind of unknown, and it's a pretty common medication that we give for IBS. It is classified as an antidepressant, but it also has anticholinergic effects, and that is believed to be the reason that it works so well in patients with IBS. Those anticholinergic effects kind of take care of the diarrhea. IBS is a chronic disease. This is something that Sarah will live with for a long time, something that she's going to have to kind of handle partly by herself because of the stress aspect of it. The causes of it are a lot of lifestyle changes that need to be made, and then of course with help of the medication, the Imodium, Psyllium, and the Elavil to try to help combat the effects of the IBS.